Hi, everyone. I'm honored to have the opportunity to introduce Steve Long, who is this too loud or it's okay? It's good. Okay, great. Who is my colleague in caring for children and young adults with sickle cell disease. Here on this campus in San Francisco, we have about 40 sickle cell patients who are very devoted to, and you might have the opportunity to care for some of these patients when you're on the red team upstairs on 6C. The East Bay campus has a much larger population, but sickle cell patients universally have pain as a result of their sickled red blood cells getting stuck in the microvasculature and causing clots and inflammation. And pain is the most common reason that sickle cell patients present to care. So historically and still today, a lot of our sickle cell patients in this country wait until their pain is unbearable to present to the ED. And the reason for this is because when they do present to care, it's often not properly treated, and instead it's dismissed and misunderstood by medical providers. Sickle cell patients in California are 90% African American and 10% Hispanic. And sickle cell disease is really a striking example of how both interpersonal and structural racism are so deeply integrated into our medical system. Racism is always a part of the conversation when we talk about what prevents our sickle cell patients from accessing the care that they need. Dr. Long has dedicated himself to addressing this inequity in our system by educating people about sickle cell pain and developing standardized evidence-based treatment plans for our sickle cell patients. Dr. Long went to medical school in Georgetown. He did his internship at Kaiser Oakland and his anesthesia residency and peds anesthesia fellowship at UCSF prior to joining faculty at ZSFGH and Children's Oakland. He's the medical director of pediatric anesthesiology and pediatric pain management on the Oakland campus and is the director of our sickle cell pain program. I'm so grateful for him for all of his work and all of his help with our patients and for coming here today to educate all of us about sickle cell pain. And I really look forward to hearing your talk, Steve.
Thank you, Beth. I'm going to share my screen here. I'm sorry I'm not in San Francisco right now. That was the original plan, and then I got scheduled to work in Oakland. But here I am. Can everyone hear me and see me?
Yep.
Okay, good. So this is a talk that I've given at grand rounds at different UCs already, at Davis, LA, and now here in San Francisco. And what I'm going to talk to you about is just my clinical experience taking care of patients with sickle cell and pain at Oakland over the last 10 years. And the direction that we've taken the program at Oakland. We now are working on one trans-based sickle cell pain program, so that patients who are in Oakland or San Francisco will get the exact same care. And I appreciate the leadership of Stefan Friedrichsdorf in helping achieve that, and I think that will go live next year. But let me talk a bit about, I have no disclosures, about my pain practice at Oakland, just so you know who I am and where I'm coming from. I started this practice in 2015, and it's kind of like my private practice, like a small, it's a separate practice in addition to my anesthesia practice. And this pain service sees every single sickle cell patient at Oakland for every admission. And we do follow up with these patients on an outpatient basis, usually as joint appointments with their hematologist. I'm busy. Last month I wrote 650 pain notes. So I've been averaging in 2022 600 pain consults per month. They're not all new consults. A lot of them are follow-up. And they're not all sickle cell either. About a fifth of them, 20% of those 600, are for patients with sickle cell. And this is just a graph of the number of pain consults on average by month per year over the last 8 years. So you can see, and this is at Oakland only, not San Francisco, but you can see at Oakland, at least, as we have developed the pain service, the number of consults has gone up significantly. And now, like today, for example, about 15% of all inpatients at Oakland are on the pain service. Sometimes we get close to 20 or 25% of all admitted patients having pain consults at Oakland. But you can see how it's been trending. So now let's talk about sickle cell specifically. When the pain service was started, the average number of admissions per unique sickle cell patient per year at Oakland was 0.75. And these are pain admissions. So I'll say that again. In 2016, the average number of sickle cell pain admissions per unique sickle cell patient on our census per year was 0.75. And that is similar to the national average of admissions per unique sickle cell patient per year across programs in the country. What we've seen from 2016 to 2021, we don't have the data yet for this year, 2022, is a drop from 0.75 to 0.4 admissions per unique patient per year. So we've seen an improvement of almost 50%. In other words, there's been a reduction in admission for pain for our sickle cell patients, close to 50% over this 6-year period. Now I'm going to talk about why I think that is. I mean, it's not all the pain service. It really isn't. It's a part of it. The hematology service is also doing things differently than they did in 2016. So I would say this is a sickle cell center outcome that we're proud of, and the pain service is part of it. So if you take a step back and if you ask me, what are my general principles in managing patients with sickle cell, I guess these are the three. This is how I'd summarize it. Number one is I don't approach the patients all that differently than any other patient with like chronic complex pain. So the same techniques that are used for complex pain work for sickle cell disease. It isn't a mystery on how to treat their pain. So you just approach it the same way and you acknowledge it. You validate it, you don't ignore it, and you treat it the way you would treat any other patient with a debilitating chronic pain syndrome. Sickle cell pain is varied. It starts, of course, with vaso-occlusion, but that's not the only explanation for sickle cell pain. And the type of pain is varied. It's somatic, spastic, neuropathic, visceral. There are organs that can hurt. There are bones that can hurt. Nerves can be damaged over time. So, in a way, there are a ton of receptors that are involved in any sickle cell pain crisis. The older the patient is, or the more pain episodes that patient has had in their lifetime, the more complex the pain is. Consequently, the treatment is multimodal. You don't really know what receptors need to be blocked until you try. It's like a shotgun approach. You're not looking for just one target. You're trying to hit multiple targets at once. And the third principle, which is what I'm going to talk about mostly during Grand Rounds today, is that customized pain plans are, in my opinion, the way to do this. It's like, this is the way I describe it. This is the analogy. At Oakland, a sickle cell patient will get the blueprints for a pain plan. Kind of like if you were going to buy a house that was custom built, you would have an architect give you the blueprints, you would approve them, but the architect is really, has the knowledge on how to put the house together. So the architect is playing a big role and is making decisions that you don't even make, right? As the home buyer. But there's a whole bunch of customization that occurs as the home buyer that you get to do. And so you get to pick out the paint colors and decide where the kitchen goes and how big the kitchen is and how many bedrooms the house has. So as a physician taking care of patients with sickle cell disease, you are the architect of the pain plan, and the patient gets to customize it, just like you would be able to customize your house. And that's the way that we approach customized pain plans for sickle cell patients. And I'm going to talk a lot about that in the next 20, 30 minutes. Yeah, so I would say the most important principle is that sickle cell disease and chronic pain are two separate processes. They're two separate diseases. And the chronic pain syndrome that patients with sickle cell develop can usually becomes a disease that stands on its own 2 feet. We have patients, I have a patient right now actually who just underwent gene therapy, bone marrow transplant, and no longer has sickle cell disease, but he still has pain, even post his bone marrow transplant. And I have another patient who had her transplant, a sickle cell patient who had her transplant a couple of years ago, and she still has chronic pain, even though she no longer has sickle cell disease. Some of these transplants, though, I mean, patients have a full recovery of pain after undergoing these transplants. The younger you are, the younger you treat the sickle cell disease, the less likely patients are to develop chronic pain. But my point is that the chronic pain syndrome needs to be looked at as its own disease. And so you can have patients with sickle cell can have pain even if they don't have vaso-occlusion. They can have acute pain even if they don't have vaso-occlusion. And they can continue to have pain even if their bone marrow no longer makes sickle cells. The 3 types of pain that are common in sickle cell would be acute, intermittent. That's the one that that's how the disease starts, where you have acute pain that occurs every now and then. Over time, patients can get chronic daily pain from multiple reasons. Maybe they have osteonecrosis, maybe they have chronic spleen pain, chronic neuropathic pain. And then the 3rd type is usually the one that we see patients admitted for, would be acute on chronic pain. Some patients too don't have chronic pain, they just come in with really severe acute pain. But a lot of, I would say the most challenging patients are the ones who have chronic daily pain, who are on opioids at home, and then present with severe acute pain. Those patients are definitely the ones that require the most thought to treat properly. Another super important principle: sickle cell pain is constant. Patients have a hard time escaping it. When it occurs, it's occurring, continuously. It does flare. If a patient is in a pain episode, the pain is constant, with spikes. But because it's constant, it's best treated with long-acting scheduled pain medications or infusions. You need to match the pain therapy with the pain signal, and the pain signal is always there. So if you just treat it with short-acting IV opioids, right here, parenteral opioids, the patients are on a roller coaster. And so this is what you might see in the emergency department: is a patient comes in with sickle cell and acute pain, and they receive a dose of IV Dilaudid, and it works, but they fall asleep. And often these patients fall asleep because they're so sleep deprived because of the pain before they present to the healthcare system. So they fall asleep, and then the Dilaudid lasts for 1 to 2 hours, it wears off, and then they wake up in the same pain or worse pain than where they were before they received the Dilaudid. And so then the patients ask for a higher dose of Dilaudid because they feel like the last dose didn't work. It did work, but it's just not the right medication by itself. It's not wrong at all to give patients Dilaudid, but if all you're treating the pain with is Dilaudid, it's a roller coaster. So then patients get a second dose of Dilaudid, which is higher. The higher dose of Dilaudid will last a little bit longer. The plasma concentration will also be higher after it's given. And then patients may desat. And then the care team thinks, oh gosh, we gave the patient too much Dilaudid, but the patient's asking for a higher dose, not because the first dose didn't work, it was because the first dose didn't last long enough. And so just going up on the dose and not changing the drug is not going to fix the problem. The right approach to treating sickle cell pain is multimodally. And again, this is not rocket science. It really isn't. I think more important is just having a very organized approach than having an approach that is kind of complicated. So multimodal analgesia helps. It helps all types of pain syndromes. And so I just want to quickly go over some of these pharmacologic modes. Opioids, we've been talking about. Local anesthetics, I'm going to talk about in the next slide, but that would be like lidocaine, bupivacaine, ropivacaine. SNRIs, medications like duloxetine and venlafaxine, and then tricyclics like amitriptyline do help. Duloxetine is a great medication for patients with sickle cell because it treats both depression, anxiety, and nerve pain, and it's now recommended by the National Society. So we often give duloxetine to patients who have chronic daily pain. Most patients with chronic pain, whether or not they have sickle cell, struggle with depression, anxiety at either continuously or on and off. The issue with sickle cell pain is that patients, consider it life-threatening, and so they consider it dangerous pain. And whenever you have pain that is associated with death, anxiety goes way up. So you could also think about patient with cancer, and they're worried about their pain is a sign that the cancer is progressing. It's similar with sickle cell disease. When they have pain, they feel like there's a chance, and it's true, there's a chance that they could die. And so it's scary. And the fear of the dangerous pain only amplifies the pain signal, and it makes the pain experience worse. So remember that about sickle cell pain. This isn't like a pain that is safe for them. They don't see it that way. And so the anxiety and depression that goes with that just makes the pain worse. COX inhibitors. So duloxetine, in other words, is a decent medication for them because it helps with anxiety, depression. So COX inhibitors are non-steroidals, ibuprofen, Toradol, that kind of stuff, and acetaminophen. When it comes to non-steroidals, we don't want to overprescribe them to patients with sickle cell because over time, sickle cell patients can develop kidney disease related to their sickle cell. And so, we're careful. The doses, if you make sure, if you follow the patient's kidney function on an outpatient basis and you don't overprescribe NSAIDs, they're fine. NMDA antagonists, ketamine would be an example of this. We use ketamine universally for all of our sickle cell patients at Oakland. I can't think of, maybe every now and then we have a patient who doesn't use it or need it. But for the most part, 95% of them use ketamine when they come in for their acute pain episodes. Alpha-2 agonists would be like clonidine or dexmedetomidine. I wouldn't say they're strong pain medications at all, but they do help with anxiety. Clonidine is a great medication for patients who have difficulty sleeping at night. And that's true for all pain patients, not just patients with sickle cell. Steroids certainly help pain, all types of pain. But that being said, I wouldn't give steroids just because a patient's in pain. Although, we recently had a patient with sickle cell who had, a transfusion reaction, and I don't remember all the details, but he needed steroids, not for pain, but for this other process that was occurring. And when he received the steroids, and he had been admitted for pain, when he received the steroids, his pain improved. So my point is, if you have to give steroids for some other reason, you can tell the patients you expect this is going to help their pain, and it usually does. And then gabapentinoids like gabapentin and pregabalin, they help a little bit with sickle cell pain. I don't give them routinely, but if patients have clear neuropathic pain, then I would. Okay, nerve blocks. I just want to talk about my experience with nerve blocks because I'm an anesthesiologist. I'm an anesthesiologist. I am in the OR all the time. I constantly see procedures. My training was much more procedure heavy than it was medication management heavy. But now my practice is the opposite. I kind of am of the belief that procedures are a last-ditch effort for patients with chronic pain. And I tend to focus more on psychosocial and pharmacologic solutions. That being said, every now and then procedures work extremely well, and I'm going to talk about when I would offer a nerve block for a patient with sickle cell. So in the last 7 years, I've only done 4 nerve blocks, 4 sickle cell patients. And 3 of the 4 worked. So the first time I did it, it didn't work. And this was the scenario I was in. I think it was 2016. And the hematologist on service asked me to come to the bedside and do an axillary nerve block for a patient who had sickle cell pain in her right arm. And that was the only location, and she'd just been admitted. So I went to the bedside and I performed that nerve block. And within 30 seconds of the nerve block being placed, the pain in her right arm went away. Her arm went numb. And she started complaining of severe pain in her left arm. So the pain jumped from one arm to the other almost instantly. And that can happen with sickle cell pain because there's a central component of her pain experience. And what I mean by central is the pain is originating from her nervous system. And once the peripheral nerve had been blocked on her right side, it was reassigned to her left side. And this is how complicated chronic pain can be. But that is what happened right in front of my eyes. And I thought to myself, obviously the nerve block, it didn't help her out at all because now she had a numb right arm that she couldn't move. And her other arm was in so much pain that she couldn't move it. So then I thought to myself, I'm never doing this again. I'm never going to ever offer a patient in an acute pain crisis a nerve block. But then I did 3 other times. And each time subsequently, the nerve blocks worked. And this is what I changed. So I will only offer nerve blocks now to sickle cell patients who have been in a pain crisis for several days. And the location of their pain is very stable. So let's say they're on day 4 or day 5 of their admission for pain, and now they only have pain in their right arm, and it's been there constantly. So that would be the first criterion. The second criterion is for the pain location. And then the third is that the patient is not improving. So the patient, we've kind of hit a wall and the medications are not helping and the pain crisis is not improving. If I see any improvement at all, like if the patient says to me, my pain is a little bit better than it was yesterday, then I will not do nerve block. I'm very conservative. I would rather just wait and focus on physical function and sleep and eating and socializing and all those non-pharmacologic approaches than do a procedure. But if the patient says to me, the pain is not changing, the medications are not working, I'm suffering, and I want a nerve block, then I'll do it. And I've done that 3 times, and all 3 times it worked. And actually, it was like magic. It's like, wow, all of a sudden the patient was a new person and went home. And then the pain, it kind of like stopped the pain cycle. But I waited. I never do nerve blocks on the first day of admission. The patient has to have been in the hospital for several days. The pain has to be in a location that is innervated by a peripheral nerve, and the pain cannot be improving. It has to be like stuck. The patient has to feel like they're stuck. Okay, components of a pain plan. So we're talking about customizing a house, and now we're going to talk about customizing a pain plan. So first, I'm going to talk to you as an architect of a pain plan, how it's built. So like, what is the architecture of a pain plan? The first step is what I alluded to. We want to maximize non-pharmacologic techniques. So psychotherapy is critical. Almost all these patients suffer from anxiety and depression are widespread. Massage therapy, acutherapy is extremely helpful. It helps with both anxiety and with pain and heat. Hot showers, warm water. If patients have access to a hot tub at home, that's extremely therapeutic. About a year ago, we bought through the Sickle Cell Center a patient a massage chair, one of the electric massage chairs that massage all everything from your neck all the way down to your feet. And she still uses that every single morning to get up and go to school. So that helps her with her chronic pain. So there's a whole bunch of different things. Some patients will say, what I like is massages, or what I like is acupuncture. Almost all patients use heat. Psychotherapy is not used by all the patients, but we're working on that in a way that's, it's so important because you experience pain in your brain. And so you need to take care of your brain. And psychotherapy does that. Second, maximize non-opioids. So I talked about COX inhibitors. This is like the NSAIDs, acetaminophen, antispasmodics, medications like Flexeril, tizanidine, Valium can help with this. So patients who have back pain, sickle cell patients with back pain, are offered Flexeril or tizanidine at Oakland. And antiemetics, anxiolytics, sleeping aids, all very important. And I would say bowel regimen is extremely important for any patient on opioids, but definitely for this patient population because their opioid doses are so high. Anxiolytics, I really believe in them for patients with sickle cell who come in, feeling scared and fearful. It helps just in the short run. So we often have benzos available. And then sleeping aids is critical. I will say, most patients who come in with acute pain, once their pain is under control, they will sleep. And they might sleep for 1 to 2 days before they wake up and they feel like they've caught up on the sleep they missed. So long as their oxygen saturation is normal on room air, the patients are not over-sedated by the pain medications you're giving them. So if a patient is breathing well on room air with a normal saturation, you do not need to worry that you have over-sedated the patient with pain medications. The reason why they're asleep is probably because they're sleep deprived and they finally are comfortable enough to sleep. A very important pearl. Patients with sickle cell, like Dr. Winger said in her introduction, they usually delay their presentation to the healthcare system. So by the time they arrive in the emergency department with acute pain, they may have not slept for 1 to 2 days. And let's say it takes another 12 to 18 hours for the patients to finally get up to their room and achieve adequate pain control. Imagine if you were just kept up for 2 days in a row, how long you would sleep. So sleep is good. As a matter of fact, I tell all patients, it doesn't matter if they have sickle cell or not, your pain will not get better until you sleep well. So the first goal actually in managing acute sickle cell pain is sleep. And once the patients have a good sleep, then things start to turn around. The third piece of this architecture of a pain plan is to maximize scheduled long-acting opioids, or scheduled short-acting opioids, but some sort of scheduled opioid. We use oxycodone as the first thing that we offer our patients. We usually schedule it every 4 hours around the clock or every 6 hours, usually every 4 hours. If oxycodone doesn't work, then we'll use oral Dilaudid. For patients whose pain is more complicated and severe, we use methadone. I typically load the patients with IV methadone for a day or two before switching it to oral. A lot of patients with sickle cell in the first couple of days don't want to take oral medication, and I respect that. They want the medications to work as quickly as possible. And so it's great that methadone is available IV. It's the only long-acting opioid that we have available as IV, and it works fast and it lasts for 4 to 6 to 8 hours depending on the patient. So it is a great medication for patients with sickle cell, and we are actually moving at Oakland to giving the first dose of IV methadone in the emergency department, so that patients aren't only receiving the IV short-acting opioids I talked about, but they're getting a long-acting opioid so that they have a floor to treat the constant pain they're experiencing. And I do not, as a rule, offer short-acting opioid infusions to any patient with sickle cell. 0. at Oakland. It's just not even an option. And the reason, there are a couple of reasons. Number one, I think it's difficult to wean short-acting opioid infusions once patients have been on them for a few days. Number two, short-acting opioid infusions cause tachyphylaxis. So if you have a patient who's on a dilaudid infusion and a dilaudid PCA, the dilaudid over time will be less effective. And patients will need higher and higher doses of the dilaudid to achieve the same therapeutic result. So we don't give opioid infusions. We can get by with either scheduled oxycodone, scheduled oral dilaudid, or around the clock IV methadone. I've yet to take care of a patient with sickle cell who doesn't respond to one of those three medications. And IV methadone is always my last, the last thing I offer, and it works. You just have to find the right dose, but it works. And patients are less likely to develop tachyphylaxis to a combination of methadone and dilaudid than dilaudid plus dilaudid. And then I do offer, of course, short-acting opioids, but that's the last piece of building this pain plan. So you can either do short-acting opioids that are administered by nurses. That's my preference, and the reason is because then the nurse can enter the room, assess the patient's pain, have a conversation with the patient. The patients are less likely to be like, I don't want the patients to be antisocial during their admission. I think the more they interact with people, the better it is for their brain, and the better their pain, the more likely their pain will improve. So when a nurse is giving the medications instead of a PCA, it's therapeutic because the nurse can go in and talk to the patients. The patients don't feel like they're alone. They're less likely to be scared. It's good. That being said, some patients do need a PCA because you can only give dilaudid, for example, every 2 hours is needed. So if patients need medications more frequently than every 2 hours because their pain is so severe, then we do give PCAs. Demand only PCAs, no infusions. I like to give a PCA with a higher dose less frequently. So for example, I like if you wanted to give a patient 1 milligram of dilaudid every hour, I would prefer dilaudid the dose 1 milligram and the lockout 60 minutes than dilaudid 0.5 milligrams with a 30-minute lockout. That way the patient gets the full dose all at once and will get comfortable more quickly. And then we wean the pain plans over time. So our goal is a 5-day admission. So on the 5th day, the patients are discharged. That's our goal. Sometimes it happens over 6 or 7 days. Sometimes patients stay only 1 or 2 days. But the goal is 5 days. That's our target. We first start by weaning the short-acting opioids first, and then the scheduled opioids, and then the non-opioids in that order. So quick word on ketamine. As I said, it's an NMDA antagonist. That's the receptor that it blocks. Glutamate is one of the neurotransmitters that works on that receptor. And it's, this receptor is throughout your central nervous system. Ketamine can be administered in multiple ways: IV, nasally, intramuscular, orally. We give it IV for patients with acute VOE pain. So ketamine, it potentiates opioid analgesia. And this is a nice graph of what it does. So this is an experiment, human volunteers who were divided into 4 different groups. And what they had to do was they put their hand on a bar that had an electrical current going through it. And the current was increased, and it was painful, of course. And they measured the threshold at which the subjects let go of the bar. So like what their pain threshold was. And these subjects were divided into 4 different groups. The first group was given saline through their IV, and that's the black circles. The second group was given ketamine through their IV, which is the white circles. And you can see, as these doses go up, their pain threshold improves. And then the third group was given fentanyl only, and that's the black triangles. And the fourth group was given fentanyl and ketamine together, and that's the white triangle. So you can see when ketamine and fentanyl are given together, they are extremely effective. The pain threshold went up exponentially. for subjects who receive those two medications together, much better than subjects who received either ketamine or fentanyl alone. So that's how ketamine helps. Ketamine is like, this is the analogy I use. Giving a patient low dose ketamine is analogous to putting salt on your food. It enhances everything on their plate. So it makes everything kind of taste better. It brings out the flavors of the other pain medications the patient's receiving. It makes those medications taste their best or act their best. And also, like salt, you don't want too much of it. So if you give too much ketamine, you're going to cause a problem because the patients are either going to become sedated, they're going to kind of start hallucinating. It has a lot of side effects as the dose goes up. So like salt, it makes everything better. And everything, it enhances what the patient's already on in terms of pain medications, opioids and other pain medications, as a matter of fact. But like salt, you don't want too much of it. The ketamine order set at Oakland is similar to the order set at Mission Bay. We run this on the floors, every single floor, including even rehab, believe it or not. And that's a floor that patients rarely even have IVs on. We also run this in the NICU for older babies who have complex pain. But for our sickle cell patients, actually for all patients, except for patients with cancer or bone marrow transplant patients, the maximum dose is 5 mics per kilo per minute. And usually we start the infusions at 3. For patients who have never had ketamine before, I never start at 5, I start at 3. We have boluses that are available for all patients on a ketamine infusion at Oakland, regardless of what floor they're on. And it's part of the order set, and it's part of the nursing protocol. The boluses are 0.1 milligrams per kilo, and we max the bolus dose at 10 milligrams. So if a patient's 120 kilos, they only get 10 milligrams. They don't get 12. And they can receive ketamine every 2 hours as needed. A lot of patients with sickle cell do not need ketamine boluses, but it's an option for the ones who are more complex. The most common question I get about ketamine infusions, low-dose ketamine infusions on the floor, is what is the side effect? And I would say most patients don't have side effects. The ones that do, maybe it's 5 to 10% of patients, will complain of feeling like a little bit lightheaded, a little bit woozy, or like they're drunk, they feel inebriated. And what I do when I hear a patient report that side effect is I don't turn the ketamine off, I just turn it down. So if the patient was on 3, we decrease to 2 or 1. And then usually the side effect goes away. And I hold the ketamine dose at the lower dose for the next 24 hours. So then the next day, the side effect usually has not come back. And I'm able to go back up to the original dose it doesn't bother them anymore. Hemodynamic side effects are very rare with low-dose ketamine. You hear about how ketamine can increase your heart rate, increase your blood pressure. That's true, but it's dose dependent. The doses that we give on the floor are so low that we just don't see it. Now, that being said, if you had a patient, have severe pulmonary hypertension or patients who are sensitive to increased pulmonary vascular resistance, I would be careful giving those patients ketamine because you could throw off their delicate cardiovascular system. But the vast majority of patients tolerate low-dose ketamine from a cardiovascular standpoint without any issues. So which sickle cell patients are good candidates for ketamine? I put them in 1 and 2 groups. Patients who don't tolerate opioids. So you have patients with sickle cell, all patients who receive opioids, some of them are not going to tolerate the side effects. They will become really constipated. They'll become really itchy, nauseous. they'll develop hyperalgesia. So those patients benefit from ketamine because you can give ketamine and you can lower the dose of opioids or even stop the opioids. But usually what you're able to do is you start a ketamine infusion and then continue the opioids they're on, but at lower doses. And because the opioid dose is lower, the side effect profile for opioids improves. But because ketamine is given, the analgesia is the exact same at the lower dose of opioid. And then the second category would be patients with sickle cell who are too tolerant to opioids. So patients who have become overly tolerant, and they're needing higher and higher doses of opioids to feel comfortable. So that patient population, that patient group, really benefits from ketamine. It's just, I know that everyone on this call has had a patient where the opioids just have stopped working, and you don't know what to do other than go up on the dose. But of course, the higher the dose, the more side effects patients have. And if it doesn't really help, if you double the dose and the pain score only goes down by a half point or something, what was the reason to do that? It's just, you need to find a different drug, right? And ketamine is that option. So this is what a sickle cell pain plan looks like. Like, this is kind of, again, like the blueprint of your house, or the blueprint of the pain plan. We organize the plan with rows and columns. The rows are the day of admission. So day 1, and I don't have day 2, 3, and 4 here, but I have day 5 because there wasn't enough room. And then the column is the drug and the dose. So what I tell patients when I'm making these pain plans, when we're making them together with the patient, is I say, what we're going to end up doing is micromanaging every single milligram and the dose of the drug should be spelled out in this plan and agreed upon by the patient. So each column is a different drug. And so, for example, on day 1, the patient, one of the drugs is going to be a short-acting IV opioid, and it could be Dilaudid or morphine. And these are the doses that we, recommend to start with. We have a scheduled oral opioid. Like I said, oxycodone is our go-to, but you can choose any scheduled oral opioid. Dilaudid is another example, oral Dilaudid, not scheduled IV Dilaudid. And then ketamine. All patients are offered ketamine, and most patients respond really well to it. We have an NSAID. We max out our Toradol at 15 milligrams for sickle cell patients, regardless of how much they weigh. And then acetaminophen. And we start with IV acetaminophen on day 1. And then over time, everything kind of gets weaned. And I have here, I just want to show you for ketamine, I allow sickle cell patients to choose whatever dose of ketamine they want within a range of 1 to 5 mics per kilo per minute every day of their admission. It gives them something to work with, so they feel like they have some flexibility. And I've never really had a problem at all with that approach, allowing patients to completely control the dose of that drug within that range. So by day 5 of an admission, the short-acting IV opioid has dropped off. The oxycodone has changed from scheduled to as needed. The ketamine, again, it's whatever the patient wants. A lot of times patients are still on ketamine on the 5th day, and then we just stop it before they go home. The Toradol has changed to naproxen, and the Tylenol has changed to oral. So this is a very basic sickle cell pain plan at Oakland. And this works for a lot of patients, especially the patients who are a little bit younger. Now, this is an example of a pain plan that is more complex or stronger. This is an example of a pain plan that we've used for a patient who has really severe chronic pain and comes in with acute pain. So instead of having Dilaudid administered by a nurse as needed, we started Dilaudid PCA, demand only, and on day 1. And then the scheduled opioid is not oxycodone, but IV methadone. We have a maximum dose of 10 milligrams, not 5 milligrams, 10 milligrams. Don't think the drug is working. But it's not a problem with the drug, it's a problem with the dose. So you have to find the right dose, and most of the time it works beautifully. The ketamine is the same in this pain plan. So is the Toradol and the acetaminophen. And then by day 5, the dilaudid PCA has been replaced with oral dilaudid as needed. The IV methadone has been weaned to once daily from every 6 hours, and it's been changed from IV to oral. And often we send patients home with a short supply of methadone if they're not already on it at home, just so that they don't have opioid withdrawal. Ketamine is the same. And then as before, the Toradol becomes naproxen and the acetaminophen becomes enteral. There are a whole bunch of other medications that we think about for these patients. I talked about bowel regimen. For itching, you can give a low-dose Narcan infusion. You can give Benadryl, but I would recommend against IV Benadryl because that can cause a high. And we've had patients, it can cause like behavioral problems in patients who get fixated on it. But if Benadryl is given orally, it works just as well for itching as the IV formulation. And I don't know, it's just, there's less drama with it. So I don't offer, I've already said one thing we don't offer is IV opioid infusions. Another thing we do not offer any patient with a VOE pain episode is IV Benadryl. But we can offer IV naloxone. So if they don't want to take oral medications, you can do a low dose Narcan infusion. You can try Atarax too. All the nausea vomiting stuff. Most patients do benefit from a scope patch during their admission. There's hydration. Insomnia is critical. We put everyone on melatonin. Clonidine is a good medication also to give at night if needed. The antihistamines are so-so for sleep. Anxiety, clonidine is probably my go-to for anxiety, but you can use benzos as needed. Muscle spasms, like I said, Flexeril, tizanidine, benzos can help. And then for urinary retention, it's not that common, but if it occurs, I use Narcan. So in conclusion, I'm looking at the time here. We have about 10 minutes, so this is perfect. The approach to treating sickle cell disease is similar to other chronic pain syndromes. Start by optimizing non-pharmacologics, use multimodal analgesia, really focus on the long-acting scheduled parts of your therapy because the pain is constant. Customize, customize, customize. This is the way to approach sickle cell patients with pain. It really is not a one size fits all. Every patient's different. Every body is different. Every pain episode is different. Even within the same patient, the pain episodes jump around. So the more customized the pain plan can be, the better. Typically, the way that we do it is the medical team, the hematology team, and the pain team together come up with a draft pain plan. We give that draft to the patient, ideally on an outpatient basis, but sometimes we do this on the inpatient side. The patients look it over and then they give us all their feedback. And then we incorporate their feedback into the final document. And then that's the document that we use going forward. The pain plans are not, they're not like written in blood where you can't change them. If they need to be changed in the future, they're changed. If a patient comes in and their pain episode is not their typical pain episode, let's say they come in with acute chest, for example, or with a pulmonary embolism and they're in pain, then the pain plan doesn't really apply to that. You can use the pain plan as kind of like a general guide, but we don't stick to it if the pain episode is not usual or typical for the patient. And then ketamine, often benefits patients with sickle cell. It's great because it's like salt. It makes everything work a little bit better and taste a little bit better. You don't have to use as high of dose for your opioids. And because ketamine is given as an infusion, it matches the constant pain signal that the patient's experiencing. Okay, that's it. I'll take questions now. Let's see here.
Thank you, Steve.
Sure.
If you wanted to answer the question in the Q&A for Nadia, do you see that one?
I do. So it says, what's the maximum lockout period you use for demand-only PCAs? The maximum would be 60 minutes, and the minimum would be 90 minutes or 10 minutes.
Great, thank you. And then we'll open up to the live audience. Rod?
Thank you for such a comprehensive review, like way to manage this kind of pain. One thing that I was wondering was, you really emphasize the importance of sleep for these patients, and what systemic stuff needs to be done within the hospital to support sleep in terms of frequency of vitals?
Yeah, so sleep is critical for everyone who's sick and is trying to heal. So at the hospital, I mean, the vital signs in the first 24 hours we have to monitor these patients because they're at such high risk for medical events occurring during a pain episode. So there are going to be interruptions at night from the nurses and the medical team because we have to keep such a close eye on these patients. But IV medications allow for fewer interruptions at night because they can be given without waking the patient up. The patients should be in a dark room. The quieter, the better. If you can have a private room, that's great. I know you have those at Mission Bay at Oakland. That sometimes can be difficult for us. We like to put the patients, kind of at the back of the room, so that like further away from the door if they're in a shared room. And then, anything, if you can provide the patient's earplug. Bed if they can, participate in physical therapy if that's what they need, move during the day so they can sleep better at night.
Thank you.
Yep.
Glenn?
Yeah, thanks. I have two questions about ketamine. The first is, I think you said a higher infusion rate option for patients with cancer and bone marrow transplants, and I'm just curious why that would be. And the second is a more general question of, like, if it's so good and the side effect profile is so nice relative to opiates, why are we not using it more?
Well, so at Oakland, we've been infusing ketamine 24 hours a day, 365 days a year for the last 8 years straight. There hasn't been 1 minute of the day that we haven't had at least one. So I assume you guys use it frequently in San Francisco too. Maybe you could use it more. Maybe we do use it a little bit more at Oakland than you do there. No, I think I mean, ketamine by itself is not gonna be enough, but I think it is a great component of this pain plan and the pain approach. I couldn't do it without ketamine. I mean, the patients would not be as happy. It really, really works. And it's cheap. Yeah. Doesn't cost that much money.
I guess what I'm saying is we tend to add it on after the opiates seem to not be working, when the way it's described, it seems like it could actually prevent us from getting up on these higher doses of opiates, which is
I see what you're saying. Right. Yeah, I think like you saw how the pain plans are structured. Ketamine is started on day one. And what I would like, I wish that we could actually start ketamine infusions in the emergency department for patients who are going to be admitted, so that they don't have that gap in care or that gap in pain delivery between when they leave the emergency department and when they arrive on the floor. If we could start a ketamine infusion really early, like when the decision is made to admit a patient from the emergency department, then that's the biggest win. Yeah, the sooner you start it, the better. Good question.
Steve, Glenn also asked why the higher dose for cancer patients versus sickle cell patients.
Oh, well, so the cancer patients in general are on number one, they tend to have been admitted for a long time. So cancer patients who receive high doses of ketamine have typically been in the hospital for months and are deteriorating. The higher doses of ketamine have more side effects, and the patients with cancer seem to tolerate those side effects better than other non-cancer patients. Also, the patients with cancer tend to be on higher doses of opioids for a longer period of time. I'm not talking about all cancer patients. I'm talking about a subset of really complex pain cancer patients who it's like we've run out of options, and the patients are they're on maximum doses of opioids, and ketamine at 5 is just not enough. And so then we'll go up to 6, 7, 8, 9, or 10. And by the time we get to 10, it usually is enough. But they're sedated at that dose. But that is usually okay for those particular patients. Same goes for the bone marrow transplant patients. Like when they get really severe mucositis and whenever they're awake, they're in pain, the higher doses of ketamine help them.
Steve, I had a question. I immediately admit that I haven't really taken care of sickle cell patients since I was a fellow in critical care and saw them at Oakland. But I thought that the idea behind the nerve block was not just pain, but also that it reduces inflammation. So I thought that the data suggested that the use of nerve blocks for patients who truly have an isolated pain crisis in a limb was pretty strong. But I'm getting the sense from you that you're not doing it because in some patients, then the pain then jumps over.
Yeah, well, if the pain is truly isolated, I agree with you completely. However, in my experience, and this is just where I'm coming from. In my experience, in the first 24 to 48 hours of a pain crisis, pain can jump around. And it may start in a patient's back and then go to the patient's chest. It may start in a patient's arm and then move to the patient's leg. And it's very migratory at the beginning and severe. And so during that window, I don't offer nerve blocks. It needs to stabilize. And I need to be convinced as the one providing the nerve block that the pain really is stable and isolated. And then at that point, once I have enough data to say that with confidence, then I'll do a procedure. And then it works. It works really well, just like you said. More questions?
Is there a role for buprenorphine in PBN?
Can you speak up a little bit? I'm like leaning towards my microphone.
She asked if there's a role for buprenorphine.
Buprenorphine? Yeah, so yes, absolutely. The older the patient, the more likely they are a buprenorphine candidate. The patients who have been on opioids for a longer period of time also fall into that category. We, on an outpatient basis, we do use buprenorphine for our young adult sickle cell patients. And some, really benefit from it. It's like I said, it's no different than other chronic pain syndromes. When you would select buprenorphine for those patients would be the same reasons you'd select it for a sickle cell patient. And yes, we use it, and it works. It works really well, and it's safer, than high doses of other opioids. Any last question? I know it's 1 o'clock.
Thanks so much, Steve.
Okay, thank you, everyone.